Hello, everyone. My name is Cassidi Goll, and I will be presenting our work titled Promoting Breast Health Awareness, Can a Sensor-Enabled Training System Help? This project was carried out in collaboration with the Department of Surgery's Technology-Enabled Clinical Improvement Center, Techie Center for short, directed by Dr. Carla Pugh, and with Pamela Ratliff, who serves as the Program Director of Educational Initiatives and Partnerships at Stanford Cancer Institute's Office of Cancer Health Equity and Community Engagement. So when it comes to women's breast health, we have found that the breast self-exam remains to be a very important aspect of breast cancer detection. According to a study published in the Journal of Clinical Oncology that looked at 222 women aged 40 or younger that had been diagnosed with breast cancer, 79% reported that they identified their cancers through breast self-exam, BSE for short. Further, a 2011 study published in the Journal of Women's Health that surveyed 361 breast cancer survivors from a broader age range of 20 to 70 plus indicated that 25% detected their breast cancer using the breast self-exam. Despite these findings, the U.S. Preventative Services Task Force does not require clinicians to teach women how to perform the breast self-exam. So to address this challenge, our team has developed a mobile sensor-enabled training system to teach women how to properly perform BSE. Funding for this technology came from a 2010 NIH R01 grant to capture clinical breast exam performance data from practicing clinicians. Due to high demand and early success with this tool, our team has altered the technology to cater to lay women. The breast simulators are made with sensor-enabled technology that communicates with a tablet-based training. The sensor technology integrated into the training system allows women to experience the sense of touch associated with performing an effective breast self-exam, and also receive real-time feedback benchmarked against our extensive database of breast exams performed by expert physicians. The breast skins are made in-house by Techie Center personnel using a mold and silicone-based materials. The high-fidelity models are non-homogeneous and emulate different breast types with varying densities, colors, sizes, and abnormalities. So once we had the system functioning properly, thanks to pilot data collections conducted at the University of Wisconsin, our team sought to validate the efficacy of the training system as both a hands-on learning tool and an icebreaker for communicating learning needs and fears around breast health. We deployed a data collection at the Stanford Cancer Institute's 2009 Breast Cancer in African Americans event, where survey, sensor, and anecdotal data was collected from 61 participants. The breast model that we used in the study had a single hard mass embedded in it. When it came to analyzing the survey and sensor data from the Breast Cancer in African Americans event, we found that participants were able to successfully identify the mass 65% of the time and used an average force of 7.2 newtons. Our previous work published in the New England Journal of Medicine revealed that practitioners who use less than 10 newtons of force are actually 70% more likely to miss a lesion. We also looked at participants' confidence in their abilities to perform the breast self-exam, and only 10% answered very confident pre-training, whereas post-training, the reporting for very confident jumped to 66%. Diving into the demographic survey data, we asked participants to indicate their ethnic background, age, travel time to see their primary care physician, and county of residence, among additional variables that we hope to publish on in the future. For ethnic background, 77% of participants indicated Black/African American, 2% Native American, 7% white, 5% other, and 10% left the question unanswered. As for age, 54% indicated 55 plus, 16% indicated 45 to 54 years old, 5% 40 to 44 years old, 13% 25 to 39 years old, and 11% had left the question unanswered. 60% of our participants traveled 15 to 30 minutes to see their primary care physician, and the bulk of our participants reside in Alameda County, followed by Contra Costa, then Santa Clara. Marin, Sonoma, and Napa counties were not represented in our participant pool. For looking ahead, we would be really interested in conducting similar data collections in other parts of the Bay Area to compare travel times, demographic variables, and levels of breast health engagement, such as number of breast exams and/or mammograms per year. The amalgamation of our insights from the Breast Cancer in African Americans event demonstrated that the integration of sensors into the breast exam training system allowed for objective, evidence-based assessment of hands-on skill and left women feeling more confident about their ability to perform the breast self-exam. And although the US Preventative Services Task Force does not support teaching the BSE to women, we firmly believe that women need to interact with their breasts to be aware of any changes and be informed advocates for their breast health. We see the breast self-exam as a vehicle for early detection, which is critical to improving breast cancer outcomes and addressing inequalities in breast health. So looking ahead, we would like to build on this work and take a deeper dive into the multiple factors that contribute to the underuse of preventative breast health services among subgroups in our catchment area. We would then like to use these insights to inform the design and testing of a full-scale, culturally tailored, community-based intervention to improve engagement in breast cancer preventative practices and services among a wider variety of communities at high risk. We appreciate the opportunity to share our work with all of you here today, and I invite you to share any questions or comments that you may have using the contact information at the bottom of my poster. Thank you so much, and happy Holman.